Upon progression, the patient still had a well-preserved performance status with ECOG 0 and was then started on regorafenib at full dose of 160 milligrams daily, which he tolerated well except for mild fatigue. So the next question becomes what to do upon the progression of the patient who was on sorafenib in this case and then had progression of disease in the lungs that was verifiable on imaging. Until recently, we really had no standard second-line therapeutic options post-progression on sorafenib. Now with the RESOURCE trial, we have evidence that patients who had verifiable radiologic progression on sorafenib and who had tolerated a minimum dose of 400 milligrams daily for the last 20 of the 28 days that they were on therapy with sorafenib and were randomized subsequently upon progression to regorafenib versus placebo had a survival benefit. They had improvement in overall survival, progression-free survival, as well as a response rate around 6 to 7%. So the RESOURCE trial showed a benefit from regorafenib post-progression on sorafenib in all endpoints, overall survival, PFS, and response rate. The other caveat is that the RESOURCE trial was restricted to patients with well-preserved liver function and Child-Pugh cirrhosis. So they had verifiable progression, they had tolerated sorafenib reasonably well, and they had well-preserved liver function. So based on the RESOURCE trial, these would be the patients that would meet the indication for the usage of regorafenib post-progression on sorafenib, and this patient certainly met those criteria. The clinical experience with regorafenib is now, for hepatocellular carcinoma, is now just starting. Based on the RESOURCE study, patients were started on the full dose of 160 milligrams daily. And when reviewing the adverse event profile, it is interesting to note that the therapy was largely well tolerated. About 40 to 50% of patients require dose interruption or reduction. So this is something that treating physicians should be aware of. But the initiation of 160 milligrams daily was certainly feasible, and the liver function appeared to be well preserved. So the rate of significant grade 3 and 4 adverse events related to liver function, such as elevated bilirubin, ascites, were really no different between the regorafenib arm and the control arm of best supportive care or placebo. So I do tend to start patients on the full dose and do a dose reduction as appropriate.